The pronunciation is difficult even in Greek, so you did very well. So my topic is on the impact of anabolic steroids on the female reproductive system, and we'll start with the definition. Anabolic androgenic steroids, in short AAS, often shortened to anabolic steroids, are synthetic steroidal androgens which promote the growth of the skeletal mass, that's why they are called anabolic, and the development of male sexual characteristics, that's why they are called androgenic in both male and females. As regards to history, they first discovered in 1930s to promote muscle growth and improve athletic performance. However, in the 1980s, use has spread from competitive sports to leisure and fitness sports. In 1975, the International Olympic Committee first banned the use of these substances. Nowadays, AAS are the most widely misused appearance and performance drugs, in short, APEDs, and their use became a serious global public health problem. Medical indications for using AAS are delayed puberty and hypogonadism in men, reduced libido, cachexia relating to chronic disease and hyperplastic anemia in women, and cachexia associated with AIDS, severe burns, and renal failure, or hereditary angioedema in both sexes. Although AAS are controlled substances, which means only to be prescribed by a physician in order to treat these conditions, it is currently possible to obtain anabolic steroids illegally without prescription. Individuals use AAS, first of all, in sports, especially in competitive power sports, such as weightlifting, athletics, football, rowing, swimming, boxing, and cycling. Secondly, for recreational reasons, such as in bodybuilding, or for cosmetic reasons, for body sculpture. Finally, they are used for occupational reasons. There is a high prevalence of use in police officers, security officers, armed forces, and professional sports. AAS use in women is usually accompanied by extreme dissatisfaction with body image and a body dysmorphic syndrome called muscle dysmorphia. Is also accompanied by a rigid dietary practices termed eating disorder bodybuilder type, and sometimes it is accompanied by non-traditional gender roles. Some common myths related to the AAS use are that steroids are safe, steroids abuse is not really a big public problem, that injectable steroids are safer than oral, that steroids don't really stunt your growth if you are an adolescent, and steroids can't be addictive. And also, steroids are not as illegal as other drugs. Finally, there is a myth that women don't use steroids. Epidemiologic data have shown that the global lifetime prevalence rate of AAS abuse is 60.4 for males and 1.6% for females, while the lifetime prevalence of use in high school boys and girls is 4% and 2% respectively. Although there is a high prevalence of use in adolescents, the average age of onset of use appears to be in the early 20s, usually between the age of 22 to 24 years old. Before I will carry on, I would like to remind you some data regarding the pharmacology of testosterone. We all know that testosterone binds directly to the androgen receptor. In target tissue where intracellular enzymes are present, the action is mediated by metabolism. Therefore, testosterone is irreversibly converted by the enzyme 5-alpha reductase to dihydrotestosterone, which is a more potent androgen and binds with greater affinity to androgen receptor, mainly in skin, genitalia, liver, and brain. Or testosterone is irreversibly converted by the enzyme aromatase to estradiol, which binds to estrogen receptor, mainly in adipose tissue and brain. As we said, the anabolic androgenic steroids are synthetic derivatives of testosterone, which means that structural modifications have been made of testosterone molecule have been made in an attempt to maximize the anabolic effect but minimize the androgenic, to reduce the rate of inactivation and alter the pattern of metabolism, and finally to decrease aromatization to estrogen. Dissociation of anabolic from androgenic effects can occur at cellular level depending on the intracellular metabolism of the anabolic steroid. I would like to mention here if a steroid has androgen sensitive tissue is converted to a less potent androgen, then you can avoid these androgenic effects. Or it could be, the dissociation could be happen at molecular level. It is hypothesized, it's not, it is a speculation, depending on the distribution of androgen receptor co-regulators in various tissue. At the moment, complete dissociation of anabolic from androgenic effects from the substances that have been developed till today is not possible. What about the route of administration? The AAS are taken either orally, transdermally, or intramuscularly. Testosterone remains popular because of its easy access, it's very cheap, and also the challenges in distinguishing the endogenous from the exogenous sources. However, testosterone is metabolized rapidly in the body. That's why testosterone esters and ethers have been developed to enhance bioavailability. Types of steroid substances to enhance bioavailability are esters of natural AAS, such as testosterone enanthate and cypionate, or of synthetic AAS, such as nandrolone, that are typically taken by injection. The 17 alpha-alkylating androgens are orally active. However, they possess a high potential for hepatotoxicity, which simultaneously limits their use. A number of transdermal testosterone preparations have become available recently, but it is very difficult to deliver large amount of this of testosterone using this route. Commonly used AAS are from the oral agents oxymetholone, known as Anadrol, oxandrolone, known as Anavar, methandionone, known as Dynabol, stanozolol, known as Winstrol, and testosterone decanoate, known as Restadol. From the parenteral agents, the most commonly used is nandrolone, and then testosterone cypionate, enanthate, and propionate, while bolderone and trembolone are aimed for vet use, but they are still used by humans. If we compare the anabolic to androgenic ratio of AAS, having in mind that testosterone as a reference steroid has a ratio around 1, oxymetholone has 7, stanozolol 8, oxandrolone 13, and nandrolone 11. What about the doses? It's very important to remember that the doses of AAS to achieve the cosmetic and the athletic effect could be 10 to 100 times higher than the doses used to treat medical conditions. Can you imagine this? The action of AAS in increasing skeletal mass and strength in women as well as in men is not under question, this is for sure. And it is known that it is dose dependent. It was a common knowledge and has been in practice since the early 1960s for male and since 1968 for female athletes in one of the most successful sports nations of all times, the German Democratic Republic. Doping with these substances was so spectacular in female athletes that rapidly spread not only to Eastern Bloc countries, but since 1970s to countries of the Western world like West Germany and particularly in the USA. The World Anti-Doping Agency, in short WANTA, was founded in 1999 to consistently apply anti-doping policies across sports organizations and governments around the world. Sports with the greatest numbers of anti-doping rules violations in 2015, according to WANTA, were bodybuilding, athletics, weightlifting, and cycling. The truth is, however, that non-athlete users account for the bulk of anabolic steroid misuse. What about the legal status? This varies from country to country. In the USA, they were classified as Schedule III controlled substances, which means they require prescription. Possession without prescription is a federal crime and it is punishable up to 7 years. In Canada, they were classified as Schedule IV, which means that possession is not punishable. They're also illegal without prescription in Australia, Brazil, and Portugal. But they are legal in Mexico and Thailand. And here is the... And in 2004, the Anabolic Steroid Control Act also classified steroid precursors, with the exception of dehydroepiandrosterone, as controlled substances. People need to be aware that products that marked as nutritional dietary supplements usually contain steroid precursors, such as tetrahydrogesterone, dehydroepiandrosterone, androstenedione, and androstenediol. A variety of adverse effects of AAS use on several organ systems have been described, including cardiovascular, hematologic, psychiatric, hormonal, and metabolic effects. In the second part of the lecture, we'll focus on the adverse effects of AAS on the female reproductive system. At this point, I have to say that our knowledge regarding the adverse effects is based only on case reports and on few retrospective studies. I don't have many studies to show you. Unfortunately, controlled clinical trials on the side effects of AAS are difficult to be performed due to ethical reasons. And we'll start with animal studies. Animal studies in female rats and mice have shown that administration of nandrolone not only results in decrease in serum levels of LH, FSH, progesterone, and estrogen, but also cause damage of the ovarian tissue irreversibly and irreparably. Both folliculogenesis and luteogenesis have been severely affected in a dose-dependent manner. The administration of nandrolone in these animals resulted in follicular apoptosis, ovarian degeneration, and atrophy, findings that have also been observed prescribed in women exposed to androgen excess, either from endogenous sources, such as in congenital adrenal hyperplasia or PCOS, or exogenous sources, such as in female-to-male transgender. The androgenization of women and adolescent girls, as we have already said, was the most effective part of the GDR cigarette doping program. A groundbreaking research was made by Brigitte Beredock and her husband, Professor Dalpiu Franke, who have succeeded in acquiring a lot of scientific reports that have not been destroyed after the reunification of Germany in 1990. In these reports, virilizing side effects in male athletes were frequent and pronounced and included, here is, I cannot see it anyway, it is, I would like to read it as it is excessive hirsutism, acne, folliculitis, amenorrhea, polycystic ovary syndrome, deepening of the voice, and nymphomania. This is what they report.
The last one
is the most important. Well, AAS use can also be associated with menstrual, based on all of this data, we can say that AAS use can be associated with menstrual irregularity and infertility due to a negative feedback in the regulation of the hypothalamic pituitary gonadal axis and a subsequent suppression of pituitary LH and FSH secretion, and also may be associated with suppression of gonadal steroidogenesis. Adverse effects also, we need to remember that are dependent on the sex, the dose, the duration, the route of administration, and the susceptibility of the individual. This includes genetic factors, age, lifestyle. AAS can also cause masculinization, and as we already mentioned, we can have acne, hirsutism, alopecia, mammary atrophy, irreversible deepening of the voice, and irreversible clitoris hypertrophy, although no well-documented data exist regarding the irreversibility of clitoris. And finally, it seems to be no connection between the AAS use in young female athletes and breast cancer. As regards the androgen and breast cancer, I would like to just mention to you that we all know that advanced stages of mammary gland carcinoma had been treated with testosterone from the 1940s until the 1970s. In vitro studies, both in animals and humans, have shown that androgen blocked the proliferation of breast cells caused by estrogens and the expression of estrogen receptor genes, actions that probably be mediated through the androgen receptor. Finally, there is a recent 10-year prospective observational study shown a reduced breast cancer incidence in women pre- and postmenopausal treated with subcutaneous testosterone. In the differential diagnosis of an athlete with menstrual irregularities, you have to remember that chronic strenuous exercise can often result in the same symptoms due to the disruption of the GnRH pulse generation and to the female athlete triad of low energy, menstrual irregularities, and low bone mass. What about addiction? Are anabolic steroids addictive? Studies have shown that 32% of people who misuse AAS develop dependence syndromes via at least 3 separate pathways: the anabolic, the androgenic, and the hedonic. Symptoms of the dependence can include tolerance, which means that you need higher doses in order to achieve the same result, or withdrawals once the AAS use stops. Withdrawal symptoms can include fatigue, restlessness, loss of appetite, insomnia, reduced libido in men, and the most dangerous of all, depression. And how we can suspect that a patient is taking exogenous androgen use? We can suspect either patient exhibits a change in behavior, such as depression, irritability, or aggression. When the patient develops female patient develops irregular menstrual cycles and all the symptoms of the androgenization due to the androgens. And when the patient develops high hematocrit, low LH, low sex hormone binding globulin, and low ADL levels, this can go down by 20 to 60%. And how we can test if an athlete or a patient, a female patient or a male, is taking exogenous anabolic steroids. In order to test, we use the testosterone to epitestosterone ratio in urine. Epitestosterone is a natural epimer of testosterone in urine. The normal ratio is 1:1 up to 3:1. Any testosterone to epitestosterone ratio more than 4:1 is an indicator of testosterone abuse. By using this method, we eliminate the influence of urine density variations. However, it's not perfect. There are 2 limitations. The first limitation is by taking gonadotropies or epitestosterone, there is epitestosterone that can be delivered intramuscularly, can reduce the ratio. And the second limitation is that genetic differences in testosterone metabolism can result in false negative results. We can also use the carbon 13 to carbon 12 ratio in urine metabolites of testosterone using the isotope ratio mass spectrometry. This method can detect the ratio of carbon 13 to carbon 12 and any differences between. There is differences in the ratio between the naturally produced androgens and the androgen that comes from exogenous sources. And that's why we can use this ratio. The emergence of gas chromatography mass spectrometry in the late 80s as a routine testing tool tool has allowed researchers to analyze a number of compounds, such as stanozolol. However, novel compounds, designer compounds, as they call them, put athletes who want to cheat one step ahead of the testing efforts. That's why the biological passport has been established. This is a longitudinal monitoring program of the urine steroid profile of each athlete at various times. Random samples with very short notice. And by using this, the biological passport, if there is any difference in the profile, then it is suspicious of an exogenous yes, right. And by using the biological passport, we can eliminate the intra-individual variation in the urine steroid profile, which means the variation within the person. But there are still inter-individual variation in the urine steroid profile, which means between persons. And I would like to give you an idea. I will show you the urine steroid profile of a normal adult female, of a patient with PCOS, it's a lean patient, and a patient with 11-beta HSD1 deficiency. This is very important enzyme. It's the enzyme which is responsible for the conversion of cortisone to cortisol. And you can see that they are completely different. Actually, the A, S, and C are internal standards. And the steroids number 1, 2, and 3 are the metabolites of androgen in the urine, while 4 to 9 are the metabolites of cortisol in the urine. And you can see the difference here. In a normal adult female, the peak heights of the steroids, of the androgen metabolites, are higher than the normal adult female in PCO and in normal adult female. And we don't know if this gives any advantage to PCO patients when they perform. There is no data. And here is a gas chromatography of urine steroid profile before and after testosterone injection. It comes from Don Catling, who is a pioneer in testing for doping in Olympic athletes. And you can see that the peak high of peak testosterone and testosterone are equal and give a ratio of 1:1. 1 hour after the injection, the peak height of testosterone is going up and give a ratio of 20:1. And finally, this is a total ion chromatogram of a urine sample collected after the injection of boldenone. And you can see, the arrows point to boldenone and the two major metabolites of boldenone. And this urine steroid profile, we can use this as a reference to compare the urine steroid profiles of the athletes to see if they use other steroids. And we'll finish with this, and we'll carry on with the lecture, and how we can prevent the AAS misuse. And first of all, we need to admit that it is a serious public health problem, and to sensitize ourselves as health professionals to the possibility of AAS abuse. And if this is the case, we need to address the underlying cause. And we also need to raise the awareness of people regarding the side effects of these substances. And here are the recommendations of the U.S. Endocrine Society Scientific Statement Task Force in 2014. And I will read on the last one, which says that we need to conduct randomized trials of various therapeutic strategies to treat adverse effects of AAS and APEDS, which means that at the moment, no such strategies exist. And finally, how we can treat AAS abuse. And it's not simple. You cannot just say the patient stop the drugs. And it is probably will be include psychological therapy for mass dysmorphia, endocrine therapy to restore hypogonadism, antidepressant for depression, and pharmacological and psychological support for those who are also dependent on other substances. Thank you very much.